Hi, this is Kelly Williams. Can everybody hear me? Yes. This is
Yes.
Kelly Williams from the Medical University of South Carolina. Thanks for joining us for our webinar brought to you by our ECI committee. I am doing double roles tonight in that I'm presenting the case. Also, I was assigned to moderate the case, so our other ECI member, Ben Prince, will also help chime in and help moderate. And we have our senior mentor, Dr. Koneti Rao from the NIH, joining us for this case. He is works in the primary immune deficiency clinic at NIAID, specifically the ALPS clinic. And since he was one of the first attendings to really teach me about chronic lymphadenopathy in the ALPS clinic, I thought he'd be a great senior mentor to help guide along our discussion as we think about this child with early onset chronic lymphadenopathy. So we will go on. So this is a case, one of my first lymphadenopathy cases at the Medical University when I started after fellowship. The little boy is an 8-week-old who previously a healthy boy who initially presented to medical care for acute respiratory distress. That was in conjunction with his first viral URI. He initially had cough, wheezing, increased work of breathing, got admitted for viral bronchiolitis, and required a 3-day hospitalization, frequent suctioning, and had an excellent response to albuterol. He was discharged and went home with a uneventful course, but then presented with a very similar picture at age 6 months. At that time, he had RSV, again, viral bronchiolitis, and was hospitalized, requiring albuterol, suctioning, and intermittent oxygen. And then he also had an influenza episode where, again, had a viral bronchiolitic picture with this requiring albuterol. That hospitalization was a little bit longer. And so at 8 months of age, he was again hospitalized with a URI. That time he had rhinovirus, but he had some really, really significant wheezings, retractions almost to his back, and was requiring continuous nebs and PICU stay, and was almost intubated for his acute and severe respiratory compromise. He eventually responded very well to steroids. He was suctioned, deep suctioning, and continuous albuterol. During that hospitalization, he underwent bronchoscopy because he was so severe, and it showed a collapsed airway, which was thought to be due to bronchomalacia. And he was discharged with nebulized budesonide twice daily to help control his wheezing. So despite the inhaled corticosteroid, he continued to have recurrent wheezing with every viral infection. And also, as he started to toddle around and walk, he was noted to have some wheezing with running or walking and increased activity, and whenever he got excited. At age 14 months, he had pneumonia, and that was treated as an outpatient with antibiotics, steroids, and albuterol. And he had some pretty significant wheezing that persisted. So he followed up with his primary care doctor after his pneumonia, and he was still wheezing a month later. That prompted a chest CT. And I will say, like, otherwise he looked completely normal, but he was noted to be wheezing. So he had a chest CT, which showed significant mediastinal, hilar, and abdominal lymphadenopathy. And that brought him in for an admission due to concern for malignancy. So he was admitted to Heme, and they started malignancy evaluation. On exam, he looked fine for the most part. He just was a little intermittently tachypnic with occasional flaring and intercostal retractions with wheezing. And then his oxygen was fine, and he was just intermittently tachypnic. He had some noted moderate anterior cervical lymphadenopathy and some shoddy posterior nodes and occipital node, and then he had one axillary node. Otherwise, he didn't look dysmorphic. He looked fine. He had no evidence of bruising or petechiae, and he had no hepatosplenomegaly. On family history that was relevant in this admission, there was no consanguinity. Mom's Hispanic, family is from Cuba, and has intermittent asthma. Dad's African American and otherwise healthy. A maternal grandfather, who was Cuban, was diagnosed with non-Hodgkin's diffuse large B-cell lymphoma at age 45. And that was treated without relapse. And then there was this history of a maternal first cousin, and who had fever, transaminitis, and splenomegaly, and persistent splenomegaly, and they thought there was a B cell problem. Originally, the child was diagnosed with CVID in early childhood, and then treated with IVIG. And then fevers and the splenomegaly persisted, and then he was diagnosed with HLH, and ultimately underwent bone marrow transplant or cord blood transplant, and then had post-transplant complications and died from aspergillus. So that was our family history. And so I just wanted to take a minute to talk about, sorry. I thought I had my bone marrow. Okay, there, sorry. Heme eval. So the white blood cell count was elevated. Hemoglobin was 11.8. Platelets were low. There were 75% neutrophils. The IgG was markedly elevated at 2430, and then IgA and IgM were normal. There was some CD4 lymphopenia that was noted, normal B cells and NK cells, and the bone marrow looked otherwise normal, except for some normocytic anemia, some thrombocytopenia, and then the absolute neutrophilia that we saw. There was no evidence of blasts. They sent cytogenetics, and that was normal. And so then we did a lymph node biopsy, and these are from one of his nodes, and it showed marked expansion of the lymph node sinuses with histiocytes, notably stained positive for 100 plus and 68 plus in CD1A minus. And there was something, and I'm not really sure how to pronounce this, but emperipolesis, I think. Dr. Rao, you can feel free to correct me.
It's okay. Finish your presentation. We'll talk.
Okay. And then abundant plasma cells, based on staining. And so they had small follicles with distinct mantle zones and regressed germinal centers. EBV was negative, and you can see, so what we were supposed to see, this emperipolesis, is when there are actual cells sucked into the cytoplasm, and the cytoplasm is usually noted to be quite pale, and that is not typically seen. And then lymph node flow showed 15% double negative T cells is what they commented on. So at that point, Heme was feeling pretty good about it not being lymphoma, and they consulted us, and we did some additional immunology evaluation. I don't know where, sorry, I have one other slide. I think it's maybe the next slide about a differential diagnosis. But the T cell subsets, their naive cells were 156. RO was 106, and then there was mitogens and antigens that were done, and there was some decreased mitogen proliferation initially, which later has corrected itself. But it was mildly decreased to PHA and POCWED, and normal to Con A, and antigens were normal to tetanus, and then no response to Candida. But he was at 1, just about 1 at this time. His HIV was negative, his EBV was negative, CMV was negative, but his IgG was positive. And because of the chronic lymphadenopathy, we also did Bartonella, that was negative, and his IgG Bartonella was positive. And then his diphtheria, tetanus were protective, and S pneumo was very protective as well. So I wanted to talk about a differential diagnosis for chronic benign lymphadenopathy. It's funny because when I first met him, or even when I first started fellowship in 2012, this list of all these immunologic lymphoproliferative disorders was much smaller, I think, that we used to talk about. But even then, as residents and on Heme as a resident, I remember recalling, it's not all cancer, it's not all lymphoma. So infections we always think about there are associated with chronic benign lymphadenopathy, or EBV, CMV, Bartonella, Toxo, and then also mycoplasma and HIV. Rheumatologic causes that often come up are lupus and Stills is what, all the people often write in our charts still. Rheumatoid arthritis and Sjogren's, and sarcoidosis. And then this is really often where we talk about things and focus things. And so I was hoping we could talk about a differential here, but I just listed some things that I think about in training at the NIH. The ones that came to me initially when I first met this kid is like, oh, we have to talk about ALPS, we have to talk about CTLA4, LRBA, which came out just after, even CARD11, XLP, and then protein kinase C, and then PI3K disease, Kikuchi, Kimura, Rosai-Dorfman. And I feel like because of my training, I saw a lot more of these patients as opposed to the lower list of patients. But do other people have other things they would add to this differential?
I will add Castleman's disease, pediatric.
Disease.
Yeah, that is another one which gets confused with. A lot of ALPS patients get misdiagnosed as Castleman, so that's the other thing to remember. That presents very similar.
Any infections that I feel like I'm missing? Carl, he has a good one for extending our differential for infections. I don't know if he's on here today.
To be honest with you, if this patient is in a different part of the world, you have to remember tuberculosis. How can you forget that? That's very important.
Yeah. Any other thoughts or things? Oh, histoplasma in the belt is what Carl has said. That's also another one.
Yeah. But remember, tuberculosis is very important in the differential diagnosis of any lymphadenopathy.
Yeah.
When you say benign lymphadenopathy, you start with that. Otherwise, you will fail your boards in India.
Also, with so many people getting BCG, it's also important to think about.
Yeah, and of course, BCG. The other major thing in PID context is if patient has received BCG and is developing lymphadenopathy, non-specifically it is BCG-induced lymphoproliferation in the context of PID. That's important.
Okay. Edith also added tularemia.
Mm-hmm.
And Carl has said, I'd caution about Bartonella. The IgM has low sensitivity.
Mm-hmm.
And I missed one other thing he said. CVID in adults. And that's certainly something I think we're thinking about as well. Yeah,
but you don't go to CVID when the IgG is 2400, remember?
Right, yes, so that's also, and he's had recurrent URIs. Gain of function CARD11, so Benta was added. That's a great one.
So my question was, patient was 14-month-old when you did the CT scan and got some lymph nodes. Was there any chest CT, or even forget CT, chest X-ray done any time when 6 weeks, 8 weeks?
Yeah, so he had a chest X-ray at the 6th month, I think, when he was hospitalized the third time, and also he had an outpatient pneumonia, so around 8 months, and that was also, he had a chest X-ray, and they didn't really comment on any significant lymphadenopathy at that time.
Yeah, but it may be a good idea to go back and look at those to see if you can guess now in 2020 hindsight. That's all.
Yeah, so I will say now, I've only seen his kid maybe 3. He's had 3 in his life, but now, if I get worried about him and he's wheezing still, that's often my go-to for when it's unexplained and he's not other sick. No other abnormality in the CT. So there were all the bronchi were open at that time. Okay, so I'm going to go on. Oh, short stature, no short stature. He was good weight.
And if there is significant nasopharyngeal lymphoproliferation, PIK3 CD is very important there to remember, because you can see lymphoproliferation pushing through the nasopharynx and even large airways. We see that, especially lymphadenopathy is very, very striking in those patients with PIK3 CD.
Saul saying family history suggests XLP type 1.
Mm-hmm, mm-hmm.
So I have a question for Koneti. So when you say that, like, I've never even seen nasopharyngeal lymphadenopathy. I mean, as an allergist, I see a lot of nasal turbinates. So when you're doing a nasal exam, what do you see? Like, you're going through the nose?
You will see if you do a upper nasal endoscopy, I mean nasopharyngeal.
Okay, so in the back.
In the back, and especially Ken Olivier, when he does when we first started doing bronchoalveolar lavage for these patients, you go bronchoscopy and BAL, and at that point you will see the infiltration of trachea with submucosal lymphoproliferation. You can see it. So the trachea looks like a colon, that's how bad it is. So once you see that, you have to suspect PI3 kinase.
Okay, good to know.
Yeah.
Okay, so we'll move on. Oh, sorry. Infections are making me think of combined immune deficiency.
Mm-hmm.
No hepatosplenomegaly. There was none. Okay, so we did an ALPS panel because we're all worried about ALPS. And
anyway, just to add a joke here, in case anyone thought it is a straightforward ALPS case, just because I am the senior moderator here, you are disappointed.
Not invited you if it were ALPS.
Go ahead.
So we had some alpha beta double negative T cells, and then the B220, 17% alpha beta double negative T cells. The ratio was less than 1, B cells 10%. So our ALP score was 2 out of 4. So Koneti, I don't know if you want to comment on ALP scores and how you feel about them.
You really want me to tell the truth? My God, if Jack Bleasing is on, he will die. I don't believe in ALP scores. This was created when we didn't have a good understanding of this condition, and it is just purely based on a flow cytometry and lymphocyte subsets, but they can change for various reasons. And now that we have seen, at least I have seen at least 1,000 ALPS patients in the last 22, 23 years. I'm dating myself. I will say ALPS score is totally useless, and it should not be utilized for day-to-day diagnosis of ALPS.
Sorry, this question is, what's the relevance of the B220 alpha beta double negative T cells?
They are the signature cell of ALPS, and nowadays we know other immune dysregulatory disorders. This is a rare population of CD4, CD8 negative and TCR alpha beta positive double negative T cells. They expand in ALPS, and more recently we published also in patients with MAGT1 genetic defect, which is the X-linked disease, otherwise known as X-Men. And I think there are a few other conditions we'll slowly realize that it's a marker of immune dysregulation. And it used to be unique to ALPS, and we used to go around saying it is signature cell, but now we know there is another condition where it can be increased in the numbers can be increased. That is, the B220 is same as the same population.
Lisa, there was a question from Lisa, but then it can't see the question. So if she wants to post it again. So it's funny. I think ALPS is just the ALPS panel is probably a good example of, the way our world is moving at this time. Mm-hmm. But we used to do a lot of functional testing before we did genetics. But now, see, it's Cincinnati, where they do one of the ALPS panels, has this algorithm of when you should send flow, mm-hmm. when you should send genetics, and when you should send something else. I think IL-18 and some other stuff. But the flow is definitely sent less now, I think. And I think it used to be more of a screening test, but since genetics are more readily available, that is usually probably where most people end up going. But at the NIH, we never used ALPS panels, but it was like the best easy screening test for when I left. And so I did the other normal ALPS evaluation things, other easy screening tests, looking for autoimmunity. He had normocytic anemia when he was a baby. His DAT was negative. His antiplatelet antibody was negative because he had thrombocytopenia. And then I did anti-neutrophil antibody, which was negative. He had an HDL, which was decreased, and a marginally increased B12. And those are both usually evaluated in ALPS evaluations. And then because of the concern for XLP, we did flow, and that expression was normal. And then actually, and I wrote PID next-gen sequencing was done, which was true, but actually the next thing that was done was an HLH panel because of the family history. And initially, HEMOC sent that because of the concern with the family history and concern for that. I don't know why. I keep getting it. Does anybody else see this? I keep getting a comment that says Lisa Forbes posting question, but
I think Lisa was just commenting that that protein expression of XIAP and SAP does not rule out XLP. And there's the second one.
I get it. Sorry, I see this now. It says it's through CIS office. I was like, it's posting a question, but it doesn't actually say her name. I get it. I see it. That's a good comment. So expression is normal, but still does not rule it out. And same with, as she says, STAT3 gain of function can also present with lymphoproliferation even without growth failure. And Carl has commented about would ALPS present with CD4 lymphopenia? And no, that is not typically the case.
Yeah, but we have seen that is the problem. When you see these patients for long, in 20 years, you see everything. So most recently, Dr. Lisko from NIH, actually, he's the first author, look it up. He published a paper in which we identified a patient with CD4 lymphopenia. He came to CD4 lymphopenia clinic and accidentally discovered to have fast defect. And then, of course, when you go back and start doing all these biomarkers, everything fits perfectly. But nobody goes around doing serum vitamin B12 and lipid profile, HDL, LDL in patients with big lymph nodes. And I strongly recommend it should be done in any patient with unexplained lymphadenopathy and splenomegaly, because that's a very easy, cheap test to do to rule out ALPS with a fast defect. Again, it does not rule out anything else. Just when I say ALPS nowadays, I mean ALPS with a fast defect. All the other so-called ALPS are so rare that we don't even talk about them. So that's my 2 cents here.
And typically, though, the B12 is like 1,200 or greater, not like barely.
Oh, yeah. B12 is like 4,000, 10,000, 80,000, depends on how you measure, where you measure. It's not marginally elevated, not 1,100. No, 1,100 is not.
Yeah, 1,100 is like barely. Okay.
Barely, yeah.
So initially, this kid got an HLH panel that was negative, and then I did a bigger panel, and this was done at the NIH. So it was like 253 genes at the time, and that was also negative. And then I sat on him for a while, and we just managed him clinically, but he wasn't really responding to treatments, and we're going to talk about that in a few minutes. And so most recently, we sent his lymph node to Dr. Diamond at Sloan Kettering. And he is looking mostly, he takes the node and does genetics, looking to help us identify, if they're upregulated, like MAPK pathway or any of those in part of the IMPACT trial. And that was all negative as well.
So, Kelly, you have not done exome sequencing yet on this patient?
So I have not done exome, and Mom, so we've talked about it a number of times, and Mom is not vastly opposed, but she is not pro. She just feels like we've done anything and everything already. But we can talk about that because she's really done that. And so I guess the question I would pose to the group is, am I really missing everything? Should I just do exome and see?
I think you have not completed the workup in 2020 if you have not done this.
Okay. Yeah, so I haven't. We talked about it. Literally, I saw this kid yesterday, and I continue to have the same conversation, which we're going to talk about in terms of management. But whole exome is always mentioned, and then we talk about treatment. And so I'll get there in just a minute. And I'm going to move through this part a little quickly. But Rosai-Dorfman disease is actually what he has. It's a pathologic diagnosis, and it was first described in 1969 by some pathologists. And Dr. Rosai and Dorfman, and they reported 34 cases of what they called at the time sinus histiocytosis with massive lymphadenopathy. It was a non-Langerhans histiocytosis with lymphadenopathy. And it's due to overproduction of histiocytes that accumulate in the nodes. And there's, to date, no genetically identified mutations that cause this. It's got an unclear etiology in terms of a pathway. But the histiocytes are always classically S100 positive, CD68 positive, CD1A minus, which was what this patient had. And predominantly, it's usually the cervical lymph nodes. It can also be mediastinal, axillary, inguinal, but almost never is it retroperitoneal. And patients uncommonly have hepatosplenomegaly, fever, pallor, weight loss, rash. It's more common in men than women, and usually, if any population, the African men are more affected. And when women get it, usually they have extranodal disease with cutaneous manifestations, and we're going to talk about that in 1 minute. It's much more predominant in children than adults, and it usually resolves spontaneously. However, those with extranodal manifestations will have less favorable diagnoses. And so these are some of the pathologic findings. We have the sinus expansion, massive histiocytes, pale cytoplasm, and this emperipolesis. And then their germinal centers can be smaller. And this is some of the skin, cutaneous, extranodal involvement. They can have massive lymphadenopathy, red nodular skin lesions. About 10% of people will have it, and they'll have a really big tongue. My kid does not have a big tongue. And this is recently from the last paper, which was in 2018, which is a consensus paper on treatment and management for it, and looking at kids or people with nodal and just cutaneous manifestations versus extra nodal manifestations and when to do what. So treatment includes doing a biopsy and then doing surgical resection if it's just one area or one node, watching the kids, and then you can offer systemic therapy. And so corticosteroids, sirolimus, low-dose methotrexate and 6-MP, cladribine, and clofarabine are all mainstays in treatment for systemic immunosuppression, and then targeted therapies when pathways are identified, specifically the MAPK pathway and things like this. And so this is a great paper for people who are interested. I will say, I'm going to pull up an email from Koneti, but he sent me an email today, and it was basically from 1969. So, Rosai-Dorfman is a rare disease. And between 1969 and now, there are more than 1,300 publications with Rosai-Dorfman in the title. So even though it's a rare disease, it is a pathologic diagnosis with a very variable clinical presentation and a lot of overlap with some of our diseases that are also rare. So my kid, he's had refractory chronic lymphadenopathy, and he continues to have recurrent wheezing. To date, his lymphadenopathy has only been responsive to high-dose steroids. He's had one admission for high-dose solumedrol. He's basically been on pred 2 milligrams per kilogram for a significant portion of his life. He's been on steroids for 4 of his 5 years now. He's had surgical debulking once, and this was all before this consensus paper came out. So in the beginning, I was trying to treat him for a steroid-sparing agent like ALPS. He failed MMF. He failed high-dose hydroxyurea, which Dr. McLean's group at Texas Children's has been using in these patients. And then he's also failed sirolimus. And based on the recommendations from the consensus paper, the next steps would be clofarabine or cladribine. We've talked to mom many times about this, and she's not interested in chemotherapeutic agents at this time. And mostly it's from a lifestyle standpoint. She really doesn't want to have lymphadenopathy, but she doesn't want him to miss out on his childhood, going to kindergarten and all these other things. And he feels that chemotherapy would lead him to be a more restrictive lifestyle. She has worked with a chiropractor, a naturopath, and yesterday she told me she's now working with a Chinese herbalist in Oregon to try and control his inflammation. She also has not been pro whole exome, but maybe we can revisit that. And so Lisa comments, whole exome, and Megan asks any changes to his ratio. So he doesn't have the platelet problem anymore. He doesn't have a big spleen at all. He's never actually had splenomegaly, but no changes to his ratio. He's pretty significant. He still has a CD4 count of 200. I think actually it's on my next slide. I did labs on him yesterday. Oh, I thought I had a slide about it. Yeah. So he's currently on 1 milligram per kilogram. He has nodes that are one chain is 5 centimeters, and then there's another node. There's another 2 centimeters on one side, and his posterior node's 3 centimeters. He has his last chest X-ray was a year ago, and it had notable mediastinal and hilar nodes, and he has occasional wheezing when he plays tennis, and not when he plays tennis, when he goes upstairs, when he does taekwondo, and at rest. So presumably from his nodes. He has ongoing T and B cell lymphopenia, and then his T cell count and his proliferation is normal. He's normal to tetanus and Candida, and he has, like yesterday's IgG was the highest I've seen it, 2,800. And so he has no extranodal involvement and otherwise is clinically well and acts like a normal kid. And so mom's just not ready to move forward.
I think your CD4 count is telling you something there.
Meaning what?
In terms of his susceptibility to infections like PCP, if the CD4
yeah, so we had him on Bactrim actually for 2 years, and then when she went to the naturopath, we dropped it because it was causing him bloating and diarrhea and some other things, and he has never gotten sick. So since I've met him recently, so I have not pushed on adding it, but she understands she understands the risks. But his CD4 count ever since I've met him has been between 240 and 300.
So the reason I'm harping on exome, of course, if you have to do exome, you have to do trio, mother, dad, mom, and child, and if any siblings, because of the strong family history of some kind of immune dysregulation right there. That's why I'm saying that
okay.
You may learn something there. That's all.
His functional antibodies are still in normal reference age. Yes. I have not done IgG subclasses on him. But we're going to have to cut it in 1 minute because I feel bad I just took too much time for Ben. But we've had great discussion. Megan's asking about somatic KRAS mutations.
I think you would have picked it up if you sent it to Cincinnati, isn't it? Cincinnati did some panel. Yeah, they would have ruled it out. Yeah, but no, I don't think you will see KRAS, NRAS without a big spleen. Here, not having a huge spleen is.
He's never had anything like that. Yeah.
Yeah, so that basically.
So it's very unsettling to me because when I met this kid, like I basically am taking care of him and I love to take care of him, but I am worried about X, Y, and Z, all of these extra things because that's how I trained at the NIH, right? ALPS and CTLA4 and PI3K, and what am I missing? What am I missing? Because I keep telling him, like in Rosai-Dorfman, they don't usually have the lymphopenia. Like, why does he have this other stuff? But in other areas, he's very, very classic, right? But I feel very uncomfortable because I call him Rosai-Dorfman with a star. There's something else going on.
Yeah, but Rosai-Dorfman is not a real disease. It's just a pathological.
Right. Oh, yes.
As I said.
Yeah, and so that was the big thing is that, Koneti wanted to also remind you is it's really just a pathologic diagnosis. It's a way that people describe this under a microscope, but the clinical presentation is very diverse and it really doesn't define, we have no explanation for any pathway of what's causing any of these things, but it's all concerning.
Okay. Good.
Okay, so I think we need to end. These are all excellent questions, and I will look into that and maybe get an update. And then Ben, please take it away. I'm so sorry.
No, that's okay. It was a fantastic case and lots of good questions. So I will help moderate the second case. The second case will be presented primarily by Kelsey Lecerf, who is a third-year pediatric resident at Nationwide Children's Hospital, The Ohio State University. I have the pleasure of knowing Kelsey because she's actually going to be joining us as a first-year fellow in just a couple of months, an allergy immunology fellow at Nationwide Ohio State. So she will be our primary presenter, and then for our senior mentor, we have the pleasure of having Megan Cooper. So I think everybody knows Megan Cooper pretty well. Dr. Cooper is the director of the clinical immunology program at the Jeffrey Modell Diagnostic Research Center for Primary Immunodeficiency at the St. Louis Children's Hospital, with focuses on mechanisms of immune cell control and natural activation mechanisms driving pediatric immune-mediated disease. So with that, I don't want to take any more time. Kelsey, go ahead and take it away.
Hi, everyone. I'm going to be presenting a case of a combined immunodeficiency with EBV-associated smooth muscle tumors. So our case involves an 11-year-old male with a history of early onset IBD and growth failure who transferred care from Saudi Arabia I'll give a little bit of his initial backstory before he came to our center. So he presented in March of 2019 with a new right-sided cranial nerve 3 palsy, with subsequent workup revealing a right-sided frontal mass. And that mass was resected in the spring of 2019 with pathology consistent with EBV-positive neoplastic smooth muscle cells. And he was also found to have tumors in the L5 to S1 paraspinal region, in his lungs, his colon, his gallbladder, and his kidneys. Following this, he was started on sirolimus and subsequently, about 5 days later, presented with disseminated non-tuberculosis mycobacterium sepsis. The sirolimus was stopped, and then he transferred care to our facility for further management. So here is some more of his past medical history. He was born full term, no complications. His immunizations were up to date, including the BCG vaccine, and he did not have any adverse events reported with any of his vaccinations. Around the age of 3, he was noted to have failure to thrive with chronic vomiting and diarrhea. And then he was diagnosed at 5 years old with Crohn's disease. And for his Crohn's disease, he received steroid induction therapy and treatment with infliximab, adalimumab, and azathioprine. He also had a history of growth hormone deficiency and was on growth hormone therapy. He had eczema and persistent asthma. And regarding his infection history, he had pneumonia around age 8 and was hospitalized, requiring BiPAP for about 1 week. And then had a history of recurrent thrush. Of note, he was on inhaled corticosteroids and azathioprine at that time. Parents note that he was cognitively normal and report that he was in the top of his class in school. For his family history, it's notable for consanguinity in his parents. They were first cousins. And for his siblings, he has an 8-year-old younger brother who has growth hormone deficiency, a meningioma, and also has EBV-associated smooth muscle tumors. The 8-year-old brother also had chronic diarrhea, but his endoscopy was negative and those symptoms had since resolved. He did not have a history of any serious or recurrent infections. He has 18-year-old fraternal twin siblings, both of which are healthy. And apart from that, just the female twin is noted to be 4 foot 10 inches. And then his other sibling died from an accidental cause. His maternal aunt has adult onset thyroid disease, but otherwise the parents were both healthy and there was no reported family history of any primary immunodeficiencies, any earlier unexplained deaths, any recurrent infections, IBD, autoimmunity, or malignancy. This was his physical exam. Pertinent findings noted in red, but he was extremely cachectic. He had the right cranial nerve 3 palsy. On his abdominal exam, he had a scaphoid abdomen with diffuse tenderness to palpation. No hepatomegaly appreciated, and just the spleen tip felt. On his extremities, virtually no subcutaneous tissue. And then I'd like to point out his weight and his height. And again, he is an 11-year-old male at this time with a weight of 11.1 kilos and a height of 111.7 centimeters. And here are his growth charts for weight and height, which show that he was significantly below the growth curve for both of those. So I'd like to pause here and see if anyone has any initial thoughts or what sort of lab test people would like to start with.
Kelsey, it's Megan. I just wanted to ask one thing about the history. I'm trying to, you had shown me this case, I'm trying to think about the growth hormone deficiency and the EBV tumors. Do you know how the growth hormone deficiency was diagnosed and were they actually responsive to growth hormone?
I do not know how it was diagnosed. Maybe Dr. Prince can chime in here, but I don't believe he was very responsive to growth hormone.
So that diagnosis happened prior to his transfer and was done mainly in Saudi. From what I can tell, he was not very responsive to growth hormone.
Okay, so that's, it was when I was first looking at this case, one of the things that I was thinking about was STAT5B, thinking about, well, is it really growth hormone failure, or are they lacking the signaling pathway for growth hormone here?
Yeah, good point. And some other things that have been thrown out from the attendees. So an RLT-PR mutation, given the early onset IBD, Carl mentions that, should have gotten some sequencing and, ruling out CGD. Luciano mentions Carmel2, a biallelic mutation there, resulting possibly in the EBV positive smooth muscle tumors. And again, the STAT5B reemphasized. All good thoughts. So just for the sake of time, why don't we just kind of continue to go forward and let's get some more detail.
Okay. So some of his initial lab work: CBC with a white count of 11.5, hemoglobin of 10, platelets at 408, diff is below. For his immunoglobulins, his IgG was 1130, IgA elevated at 665, IgM of 240, and an undetectable IgE level. CMV and EBV were undetectable at that time. Here was his initial lymphocyte subsets. Overall, relatively unremarkable, except for maybe a slightly increased percentage of his CD8 T cells. And then just to have these for everyone to see, these were some of his imaging studies. So on the left is his PET scan showing hypermetabolic activity in the skull, the L5 to S1 paraspinal mass, increased activity in his colon, gallbladder, kidneys, and chest. The central image with a right hilar mass and several pulmonary nodules. And then the figure on the right was the mass in the cavernous sinus that extended into the right medial temporal lobe and the pituitary gland. All right, and I'll move forward here and go through some of his additional immunologic evaluation before pausing again. This was his TB and NK cell phenotyping. So for his T cells, we saw an overall increased percentage of naive CD4 T cells at 83%, as well as the naive CD8 T cells increased to 77%. He had increased TEMRA CD8 cells, noted to have decreased central memory CD4 T cells with 11% and absent central memory CD8 T cells. Also with an increase in his effector memory CD8 cells and decreased regulatory T cells here. For his B cells, he had decreased total memory B cells and plasmablasts, as well as decreased switched memory B cells. And not listed here, but he had quantitatively normal NK cell subsets with normal perforin and granzyme expression. And this graph was showing the flow cytometry of his T cell proliferation after stimulation with anti-CD3, anti-CD3, and anti-CD28, as well as anti-CD3 and IL-2. And our patient is the black bar, and he had a blunted T cell response to anti-CD3 as well as anti-CD3 and anti-CD28 compared to the healthy controls, which are in the white bars. And then the very right side of the graph showing that stimulation with IL-2 partially rescued that T cell proliferation.
So Kelsey, I can tell that Roshni probably did this flow for you there at Nationwide.
Yes.
Yeah, because this is a really nice way that she does it, looking at these different stimuli. So it can be challenging to get this as a clinical test, to actually get, especially adding in the IL-2 to see if it's rescued by IL-2 or not. Which can kind of bypass some defects. And you do see some rescue. Oh, and Roshni says it was done as a clinical test. So that is good to know. So you can do this for us, Roshni.
It was actually done at Mayo, okay. I believe. And Roshni was able to grab some of the data there in order to get a little bit more information and look at it like actually directly at Nationwide.
Okay, great.
All right, so I'll pause here again and see if anyone has any further thoughts before we get into his further genetic testing and diagnosis.
I will. I'll go ahead and say Carl's point is very, very notable, in that, given the history of consanguinity, the early disease, you have to have a high suspicion for a monogenic defect. And then Lisa also mentioned that his NK cells were low. I will say that at this point in time, he had a concurrent illness as well, so it wasn't, just a straightforward healthy sample. So that may have been partially affected there. Other thoughts that Andrew Snow mentioned, that his poor T cell proliferation and low Tregs are consistent with a CARML2 mutation. Carl mentions that a functional CD4 deficiency with an invasive non-tuberculosis mycobacterial infection, might cause you to think about an IL-12 interferon gamma axis issue. All of those were things that we had thought about as well as we were kind of going forward and getting further genetic testing, which is, I think, really pointed in this patient given the history. And then mentions that IL-2 rescue did restore some of the T cell function. This patient does not have EOE as far as we know. So, Kelsey, why don't you go ahead and keep going? I think all of those are fantastic thoughts. Definitely, we were racking our brains. There's some unique things about this case, notably the EBV smooth muscle cell tumors, as well as his growth defects, and then clearly the functional T cell defect is there. So we had a couple ideas going into the genetic testing, but I'll let Kelsey kind of go forward.
Okay, so for genetic testing, as many responded in the comments, he had a SNP microarray with regions of homozygosity that were consistent with his known parental consanguinity, and those regions of homozygosity encompassed about 223 different recessive genes. And his whole exome sequencing, which was also obtained, showed a novel homozygous deletion in the CARML2 gene, leading to a loss of 10 amino acids from a highly conserved domain, and each parent was found to be a carrier for that mutation. In addition, on the whole exome sequencing, he also had compound heterozygous VUSs in DOC8, but it was felt that his overall clinical and immunologic phenotype was not consistent with a sole DOC8 deficiency. All right. So talking a little bit more about CARML2 and its function. So over here on the left, the CARML2 protein functions as a homodimer. It's involved in cellular polarity, membrane ruffling, and migration. It localizes to the vimentin membrane filaments and is involved in regulating actin capping protein. So it helps to keep uncapped actin ends so polymerization can continue. And on the right side, this shows how CARML2 is involved in the CD28 co-stimulatory pathway, with the eventual downstream signaling resulting in promoting actin polymerization at the immune synapse. Deficiency of CARML2 results in reduced T cell proliferation, activation, and differentiation that has been shown to be partially restored with IL-2. The clinical phenotype for this deficiency, they've seen recurrent infections, eczematous or striaform dermatitis, IBD, and various malignancies. So I'll go through the next slides a little bit more quickly, but these are some of the graphs that we obtained from our patient samples, as well as his brother and parents, but I'll focus on the patient in this case, which is the triangle. So this graph here demonstrates that our patient had decreased frequency of CD28 positive, CD8 positive T cells. And then on the right, the CD28 protein expression was also reduced in the CD4 T cell subset, but was actually comparable in the CD8 subset with the healthy controls, which are the black diamonds. And then this graph looks at CARML2 protein expression in healthy controls compared to our patient, and we see reduced CARML2 protein expression, which is also seen with these graphs. On the left, we see a decreased frequency of CARML2 positive CD4 positive T cells, as well as absent CARML2 positive CD8 T cells and CD3 lymphocytes. And then on the right side, we see decreased CARMEL2 protein expression across all subsets. As I mentioned before, on his whole exome sequencing, he did have the compound heterozygotes variants of unknown significance in the DOC8 gene. So these graphs were looking at DOC8 protein expression. On the left, he had normal frequency of DOC8 expressing cells, and then on the right, reduced expression of the DOC8 protein in his cell lines. And a little bit more on EBV smooth muscle tumors. So looking in the literature, they've been associated with patients who have HIV, which our patient was negative for. They've been seen in post-transplant patients and patients with primary immunodeficiency disorders. It's thought that a defect in T cell immunity is critical in their pathogenesis. They've been seen in patients with the disorders listed here. And one patient in the literature, a 24-year-old with GATA2 deficiency who had liver and spleen EBV smooth muscle tumors, was transplanted, and that cured her EBV smooth muscle tumors. Some poor prognostic factors that have been associated with EBV smooth muscle tumors include multifocal disease and intracranial lesions, as well as EBV tumors that are associated with primary immunodeficiencies. And then an update on our patient. So there was a long discussion about how to go about treatment for this patient, and it was thought that transplant was pretty much one of the only chances that he might have for survival. So they proceeded with transplant. He did receive radiation to specific intracranial, thoracic, and pelvic tumors in the hope that that would reduce his tumor burden. He received the conditioning regimen listed there, and then his post-transplant course was complicated by engraftment syndrome, respiratory failure that was attributed to PJP pneumonia, CMV pneumonitis, and progression of his pulmonary tumors, as well as possible idiopathic pulmonary syndrome, eventually resulting in his death at day plus 32 from his transplant. He did have immune monitoring labs prior at day plus 30 that showed significant lymphopenia with an ALC of 31, complete donor chimerism in the myeloid lineage, and only 46% donor chimerism in his peripheral blood CD3 T cells. In addition, an update on his sibling, his 8-year-old younger brother, who had a similar phenotype. His brain MRI does show right occipital meningioma. He has multiple liver and splenic lesions and a few pulmonary nodules as well. And his liver biopsy did show EBV smooth muscle tumors. He has not had genetic testing yet at this time due to some barriers encountered with the Saudi Arabian embassy, but it is thought that he will also likely need transplant. And I will open it up to comments and questions.
And I will also put out, before turning things over to Megan in case she has some other thoughts, that the sibling has not had genetic testing yet due to some of those limitations that we've encountered. But as you saw, you may have noticed in some of the data that Kelsey presented, he does have a deficiency in sort of an immunologic phenotype, essentially with the same kind of CARMEL2 deficiency. So a couple other things, Edith's just asking, what is the success rate of transplant in patients with EBV smooth muscle cell tumors? Megan, I don't know if you want to take that. I could talk specifically about CARMEL2.
I don't know the exact success rate. It's relatively low, as I remember. It's under 50%. It's a hard infection to get under control before transplant.
Yeah, and as of at the end of last year, we knew of, in kind of talking to some other colleagues, knew of about 8 patients who had been transplanted with CARMEL2, with about 50% of them surviving. There's currently a manuscript actually in the works, but significant roles as far as outcomes included age, disease burden, and infectious complications similar to our patient. Carl wanted to know any mechanisms to control the EBV during transplantation. Did he have EBV reactivation? I don't believe he had significant EBV reactivation. The majority of his issues were secondary to respiratory failure with the tumor and then PJT pneumonia. Let's see. Andrew Snow wants to know. He said 2 out of the 4 other Carmel-2 patients died during prep for transplant, which is notable. And I think part of the reason is these patients are sometimes identified a lot later, sort of in their course. Carl was wondering if Ritux would even work if the EBV is in the smooth muscle. We hadn't thought about Ritux. We talked a little bit about cytotoxic T cells specific to EBV with the thought that that would probably not be successful. I don't know, Megan, if you have other thoughts.
Yeah, I mean, I think the thought with Ritux would be like for like an XLP or lymphoproliferative disorders where you're just getting rid of the cells that actually have the virus. But here it's kind of gone beyond that and transformed. So I don't think that that would be of significant benefit here, unfortunately. I guess if he did have active viral infection at the time, maybe that could help that a little bit.
As you saw in some of the initial slides, his initial viral EBV load was actually quite low, and it was mainly just the tumors that were causing the burden. He didn't have a lot of EBV, just active in his blood.
Mm-hmm. I would just mention, I think this case is a great example where pairing with somebody like Roshni, who can do all of these clinical tests in her lab, looking at the Carmel-2 and looking at DOC8, because in a case like this, you're going to get a lot of homozygous variants of uncertain significance, and kind of nailing down what it is here that is causing his disease, and is it multifactorial as well, I think is a really good point that Kelsey brought up.
Agreed. As far as the if the smooth muscle cell tumors shrunk with chemo, he got a little bit of benefit from that, but it wasn't a good sort of long-term option. Like I said, he got a little bit of palliative help from that just prior to transplant. So, yeah, so that's our second case. Again, we can kind of continue to keep people posted as far as his brother. The hope was that when he was identified that, this patient's case was so far along that transplant was, was going to be quite complicated. But the hope was that maybe we would have an impact on his brother. As Kelsey pointed out, he appears to have, he just recently arrived to the US, and he appears to also have pretty significant disease. So we will continue to keep you posted. I think we're running out of time. Kelly, I don't know if we have time for our end in doing an article.
If you think you can cover it in like 2 minutes, maybe 3 minutes.
Sure.
Yeah, just do it. I think you should do it.
All right. So as part of these,
if you need to.
What's that?
I said people can feel free to get off if they need to, but I think it's helpful, very good clinical pearl.
Yeah, all right. So as part of these interesting cases, we also kind of want to highlight a recent case, a recent article. And so I'm going to quickly do that tonight. The article that I chose to highlight is just the systemic review and meta-analysis looking at the benefits of increasing IgG trough level and infection rates in primary immunodeficiency diseases, particularly on those receiving IVIG. So I'm going to fly through this, but kind of the background is that there have been previous meta-analyses evaluating IVIG troughs and infection rates. Initially, early on, the thought was like even early 2000s and before to shoot for a level of 600 or so. And in a meta-analysis done in 2010, Orange et al. Showed that actually there seemed to be an association with higher IVIG troughs being associated with lower infection rates, particularly in this meta-analysis they looked at pneumonia. But more recently, meta-analyses showed that while they looked at both IVIG and sub-Q IG, there did seem to be a correlation with higher troughs with sub-Q, but there did not seem to be a correlation with IVIG. So there was a little bit of confliction there. Onwards, we worked to this study. And, really, the objective of this study was to assess the effect of increasing the IgG trough level on infection rates. They also wanted to look at other factors, including missed school and work due to infection, hospitalizations due to infection, and antibiotic use. They wanted to perform a breakpoint analysis to determine, if there is a point at which IgG troughs increasing above a certain point has little yield or little benefit. So the methods being, and this is a systemic review, and they chose to focus on cases published from 2000 to August 2019. And this is mainly because around 2000 is when the FDA Blood Advisory Committee outlined and standardized the clinical trial design to evaluate the safety and efficacy of new IVIG products in primary immunodeficiency diseases. And this standardization enables studies to be compared more effectively. So moving on, this is just an overview of their study selection. About a total of 191 studies were identified using literature search strategies pertaining to immunoglobulin, pharmacokinetics, infection, and primary immunodeficiency. All studies were assessed by 2 independent investigators using method of the Miners scale, which is a scale utilized in comparing non-randomized studies. After removal of duplicate articles, exclusion based on predefined inclusion and exclusion criteria, they ended up on including 28 articles, which were included in the final analysis. The validity of these articles were evaluated by using both subgroup analyses as well as sensitization measures. They compared in their subgroup analyses studies with small and large sample sizes, which they limited at 40 subjects, so either greater or less than 40 subjects, children only, and mixed populations, studies with duration of more than or less than 12 months, and then studies with specific types of primary immunodeficiencies or mixed. So moving towards the results, they looked at data from 1,218 patients, and what they found was in the patients that they looked at, the most common diagnoses were common variable immunodeficiency, accounting for about 66% of the population, and then followed shortly by XLA, which accounted for 18.7%. In this population, the mean IVIG dose ranged from 387 to 560 milligrams per kilogram. Of these patients, 818 had documented IgG trough levels, and the mean trough levels ranged from about 660 to 1,200 milligrams per deciliter. They went on to do a random effects meta-analysis or meta-regression, is what I meant to say, which showed a significant decrease in hospitalization days associated with increasing the IgG trough. That's shown in the top left figure. Of note, each plot on the graph represents a single group of patients in the study. There was a trend for significance for decreasing infection rates and missed school days or work days with increasing trough, but it was not actually significant. They went on to then perform the segmented regression analysis, and they were able to identify a breakpoint trough level of 960 milligrams per deciliter, where increases in the IgG trough up to this level showed a significant decrease in infection rate. The p-value on that was 0.018. This can be seen, the breakpoint can be seen in the middle left figure, and then focused in on from less than to up to that point in the bottom left figure. This essentially applies a statistically significant 13% reduction in infection rates for each 100 milligrams per deciliter increment in IgG trough up until that point. They went ahead and then did some sensitization analysis or sensitivity analysis. Among the 28 studies, 5 of them had a follow-up of less than 12 months and showed to have a significant difference on the pooled event rate across outcomes analyzed compared to the primary analysis. When they removed these studies, the exclusion of these 5 studies did actually affect the results of the primary analysis, resulting in a non-significant decrease in the rate of infection, which was a p-value of just not significant, 0.0632. The authors then note that by applying a fixed effect model for the same subset of data, this showed a significant decline in the infection rate with increasing IgG trough up to 960 milligrams per deciliter. That was significant. So the big take-home points from this article are that patients with primary immune deficiencies on IVIG therapy who continue to have infections may benefit from higher doses of immunoglobulin replacement. Specifically in this analysis, this meta-analysis, it appeared that a titration of the IgG trough above 960 had no further improvement in the infection rate. And then I think it's just really important to not just go by trough, and it's really important to personalize your dosing and consider other factors, which include underlying diagnosis, infection history, and then what the patient's baseline serum immunoglobulin level was prior to starting replacement. So that's a quick summary of the article. Feel free to dive in and get a little bit more information and going directly to the source. And with that, I think we have our full final hour. So have a good rest of the night, everybody. Stay healthy, and we'll see you again soon.